Welcome everyone to the BitePACES webinar on cracking common cases. Um, I think I'm really excited for this webinar actually because it's particularly relevant with the exams just around the corner, which is why we decided to do it. For those of you who don't know me, my name is Shoaib and I'm the course organizer at BitePACES, and I recognize quite a few familiar names, which is excellent. It's good to see so many of you coming back. We host these webinars fairly regularly. To be honest, we haven't done them for about a month or so now, just because I've been really busy preparing for the course. But we tend to hold them in bursts and we upload most of them to YouTube. So, if you feel like you ever need to catch up or watch it again, feel free to head over to YouTube and check us out there. Just before I hand over to Vishnu, I'm going to talk a little bit about our course, no more than 2 minutes. So please do bear with me. We have our course coming up in September and October, in a couple of weeks actually. And we are very almost sold out for the September course. And we still have some spaces on the October course. So if you are interested, please do come along. It'd be great to meet so many of you in person. A little bit about our course. We have a 1-day course and a 3-day course. The 3-day course basically covers all stations. The 1-day course is more of an examination intensive with a few clinical consultations as well. We have some really nice cases, and if some of you have been on the course before, I'm sure you'll know. So yeah, head over to bitepaces.com. Top right there will take you to the website. Bottom right will take you to our WhatsApp group where we make announcements about all of our webinars, and you can ask us any PACES related questions you may have. Yeah, so I think this should still be working. There's like a £20 discount code if you put webinar 20 in. I've got really good reviews. So I think we've got almost 60 reviews now, all almost 5-star. People seem to really like the course. So, don't take my word for it. And just a few points about what makes our course unique is that we really pay attention to high yield cases. So we're less about kind of niche cases that are cool, but we're more about kind of the cases that are going to come up in your exams. So valvular heart disease, as an example, Parkinson's disease, etc. Most of our patients have tutors attached to them. You go around in pairs, so it's very small group focused teaching with data feedback, basically covering every station if you come on the 3-day course. So yeah, that's us. I'll post a link to the WhatsApp group and the course website. But what I'm going to do now is hand over to Vishnu, who's actually one of our faculty and will be teaching on our upcoming course and has taught on many of our previous courses. He's also done a bunch of webinars. He knows the exam, inside out. So he's the perfect guy to take you through this journey. And he's an endocrine registrar over at the Royal London. So Vishnu, without further ado, I'm going to hand the stage over to you.
Brilliant.
If you
Thank
are
you so
there.
much for that, Shoaib. So hopefully you can see me, and I will just get my slide shared. At Hey, so I've just got the chat open, so just in case anyone had any questions, please do feel free to ask as we go along. So I've been tasked to try and teach you about how to crack the common cases. So I thought quite hard about how to do this webinar just because I didn't want to list, you know, all the differentials and everything like that. I want to just give you the tips on how to approach the common stations, sorry, the stations that will turn up in the exam, and what common cases turn up and how to differentiate them and what the best approaches are. So we'll sort of go through um the systems as it were. So cardiology, respiratory, abdomen, and neurology, and a few others. Every single webinar, I feel like I can't do a webinar without having the wheel open. So that's um the wheel of PACES 2023. So you can see station one, respiratory, station two, it's the consultation, which I've done in the past, cardiovascular neurology, abdo. So we're going to focus on the common cases that appear in those ones. So cardiology cases. First thing to say about cardiology is the best thing that you can hope for in cardiology is that on the right, I've done a hopefully um, representative midline stenostomy scar. So I think if you've got a scar, a patient with a scar, you can be much happier about the station, is the first thing I'll say. Because you know that you're not necessarily hunting for a murmur, or you know that that patient's got one or three things. We'll come back to that. The most common things that turn up in cardiology stations are stable patients. And if you think about it, the stable patients will usually have either valve disease or the others. So bypass, HOCM, a device put in, dextrocardia because they tend to be quite easy. They're healthy, right? So you've got to think about the type of patient that will turn up to PACES. Now, aortic stenosis is extremely common, and so is mitral regurg. And people that have had valve replacements are also common. Things that are less common are at the bottom of the list, and things that are even rarer, tricuspid regurgitation, I've not even put on the list yet on this one because yes, it can turn up, but it's very unlikely compared to the others. So my tip for here is to make sure that you're confident in differentiating aortic stenosis and mitral regurgitation. So, as I said, patients with stenotomy, think valve, think bypass, or think both. Okay. So I'm just trying to keep it simple. If it is a valve, um, think what type. So when you've got these are the sort of questions that you have to answer, and these are the way to get full marks. Okay. So it's not enough to just identify that it's aortic stenosis or a systolic murmur. Okay. So if you identify as a systolic murmur, you have to characterize it. You have to say whether it's ejection systolic or pansystolic, and you have to offer which valve it is. And like I said, the majority of the PACE exam, just because of percentage wise and the amount percentage of aortic stenosis in the world, it's more likely to be a systolic murmur. It's more likely to be aortic, but that does not mean it doesn't have to be mitral. And that's why you have to think about when as soon as you approach a station, if they have um if they have a stenotomy and you think they've had a valve replacement, you need to think of which valve is replaced. And you need to think about what type of valve is it? Is it prosthetic or is it metallic? And is there any valve dysfunction? So these are the ways to get the full marks. So if you just said you went through the exam and you just said this patient's got a metallic mitral valve and you didn't offer about whether there was anticoagulation or if the valve was intact, you wouldn't necessarily get all the marks that were available. Or it just puts you in that sort of satisfactory borderline category. If no scar, that's the station becomes a bit harder, doesn't it? I mean, we've just by the virtue of the fact that you have to be there to adjudicate on most likely on a murmur. Most common types, as I've talked about, is stenosis and mitral regurg. Mitral regurg is more associated with atrial fibrillation, and carotid bruising would be aortic stenosis. Again, if you don't see a scar in the midline of the chest, I think your mind should automatically start thinking about, okay, I need to start thinking about what I'm going to hear on the chest and look at what the associated features of the murmurs. Okay, so aortic stenosis, mitral regurg, and then you can think about the other murmurs. So, an older patient, you can start seeing if there's any sort of old signs of rheumatic fever. Unlikely. But those are the sort of thought processes that you need to have. Patients with device, so those, so that's permanent pacemaker, implantable cardio defibrillator, and CRTD or CRTDP. You won't be able to differentiate really necessarily between the three, although a CRTD is probably bigger than the other two. You just need to have a list of differentials for why that was inserted in the first place. For ICD, I would suggest that you split it into terms of primary prevention and secondary prevention. Okay, so primary prevention for an ICD would be HOCM, for example. Secondary prevention is someone who's had a cardiac arrest. Um, and again, that's another way of just trying to demonstrate that not only you understand that this is a pacemaker, but you're able to just have a differential in a categorized manner rather than just listing a list of reasons why. The last tip I have for cardiology is try and think about um, what the age of the patient is and the age of the scar. So younger patients are more likely to have congenital heart disease. And it's just by coincidence, I've just read that someone has said my first exam in cardio was Eisenmenger syndrome, much to my horror. Yes. So the thing is, up and down the country, they will still have some patients with congenital heart disease, etc. The clues will be, or in Eisenmenger's, which is congenital heart disease that's progressed and etc. my tip for the thing is you're not going to see those patients on the wards, are you? Okay. So that's one of the advantages of these of a PACES course is to go through these patients. However, the majority of your exams, and I really do want to emphasize this, will not be tricks. The majority of your exams will be one of those things. Okay. So it'll be a valvulopathy, and that's either a valve dysfunction not working, aortic stenosis, mitral regurg, or a valve replacement. So that's so do not worry about the niche things. You do need to know about them and you need to be able to work through them. But I don't want you to lose marks necessarily if you go to an exam and you have aortic stenosis and you sort of don't really, you think it's a different murmur. I want you to be confident on these things. These things you can control. The majority of candidates will get these cases. I don't know if there's any other sort of questions on cardiology. Eisenmenger is a very tough one. It's becoming more uncommon because the nature of the PACES exam is to try and bring in less niche things and more things that you're more likely to see on the medical take. So that's the general move in PACES. Um, but yeah, one of the reasons why Eisenmengers would have been brought in is because you can reliably ha expect that patient to have signs, isn't it? I'm going to move on to respiratory. So I was actually trying to work out what I think was the most common presentation or case in PACES in respiratory, and that is a form of interstitial lung disease. So pulmonary fibrosis, I think, is far and by large the most common presentation in PACES in the respiratory station. COPD and asthma are very common. And then one of the reasons why COPD and asthma are very common is actually a lot of places. So another thing you need to remember about the PACES exam is that a lot of places will have to use patients on the ward because of a late cancellation, and the patient with just sort of recovering at the end of a COPD exacerbation will be of someone that could be examined, couldn't they? So that's one of the reasons why COPD is quite likely. And then you've got patients with just a chronic wheeze throughout. Um, and the other more common thing, although it's just by reports that we receive and things like that, is previous lung surgery. So lobectomy, pneumonectomy, um, and lung transplant. Um, and slightly less common, sarcoid. That's just because sarcoid is better treated now, so the signs are sometimes a bit harder to see. So I think pulmonary fibrosis, COPD, and previous lung surgery are probably the most common cases that one would expect in a respiratory station. Now, how does one approach that using that information? The first biggest tip I can give, partly because I've examined people in PACES and I've taught on the course, the biggest mistake candidates make is not identifying scars early. So some people do the entire exam and not see a scar. And it's partly because they are well hidden in respiratory. So they are, in the axilla, right at the back, quite faded. So, or under the breasts. Okay. So what I suggest is you expose the patient completely and have a real look for scars because it completely determines what your exam is going to be like. So if you see a clamshell scar, well, you're thinking lung transplant. Your exam was going to be then focused on what are the side effects of a lung transplant. So what are the side effects of immunosuppression? Is there any evidence of steroid use? That's in all respiratory patients. And finally, why did they have a lung transplant? The last question may be quite hard to answer, especially when you're not able to talk to the patient. But can you see how that could completely change the way you would approach your examination technique? Rather than just doing a normal respiratory examination and then realizing at the end that they've got very little signs if they've had a lung transplant. Steroid usage is a really good and useful thing to look for right at the start. I would just make a mental note to sort of screen for autoimmune conditions, so rheumatoid arthritis, sarcoidosis, that's your skin conditions. Because remember, the most likely thing that's going to turn up is pulmonary fibrosis. Um, and just because, just so in, if Eisenmenger is the cardio version of the got you station, primary ciliary dyskinesia, where you have situs inversus, is probably the respiratory version of I got you. So I would definitely recommend you should do this anyway in all respiratory examinations, is to palpate for the apex beat for dextrocardia. Because if you confirm dextrocardia, then you should start thinking about has this person got situs inversus and primary ciliary dyskinesia, etc., as a potential cause for a lung transplant. So that is a station that has appeared in the past. So that would be the gotcha station, as it were, in respiratory. Brilliant. Just making sure there's nothing in the chat. Please do feel free if there's any sort of comments you had. Um, I had a VAT scar and was asked what the indication of the lobectomy was. And the next question was indications of EBUS. So I wouldn't worry about that, by the way. So just in general, so people who have not never sat the exam before, and this is the first time you're sitting it. Um, so in my exam, I examined, just to be clear, I examined someone with a completely normal respiratory exam. Um, apart from the fact that they had a lobectomy. Um, so otherwise, there's no other signs. They had the VATS procedure on the left, I think. No other signs. And sorry, there was one other thing. They had a radiotherapy sort of tattoo on their breast. So and a breast scar. Sorry. So clearly they had a mastectomy, and you wondered if that was linked, the mastectomy and the lung surgery, right? So part of the questions were about that. And then suddenly I was asked about how do I manage a PE? Um, and the reason why that's more common now is because the PACES exam, like, and I can't emphasize this, is now moving away from what is the fourth line treatment for, I don't know, pulmonary fibrosis. It's moving to a fact of actually, if you're the medical registrar on my, and I'm the consultant, can I trust you to manage a asthma attack or a pulmonary embolism safely? So that's why some of the sometimes the questions aren't exact, exactly that follows. Okay, so it's not necessarily linked. In terms of your EBUS question, I'm going to hold on to that and answer it at the end if that's okay, just because that's sort of related. Is there any other questions on the respiratory station? And if there is, you can put it in the chat. Otherwise, I'll go ahead and answer the EBUS question. Right. So next question was the indications of EBUS. Feel free if you want to put it in the chat, but quite simply, it's a diagnostic procedure, isn't it? So if you've got lymph nodes, and then you can reach them, you can biopsy them, and you can make a diagnosis of cancer or reactive lymph nodes. So that's the main thing for an EBUS. I'm not entirely sure what else you can do. So it's usually infection, inflammation, malignancy, and it's usually for cancer. Onto abdo stations. I don't think there's any questions on respiratory. So again, scars are your friend because as soon as a patient has a scar, the station becomes much more focused. Okay. So in stations where there are no scars, you've got to think about looking harder for the signs. Okay. So in an abdo station, if there are no scars on the abdomen, you're obviously going to be looking hard for an organomegaly. There may not be one, but that's what you're looking to really look hard for. So let's stick with the easy side. So let's say there is a scar. Now, I forgot to put the red on this, but the most likely station or the station that comes up the most often is our kidney transplants. And that's either kidney transplants by themselves or SPKD stands for simultaneous pancreatic kidney transplants. Um, it could be SPKT. Liver transplant is less likely, but has turned up. and nephrectomies as well, because they're quite common as well. So I just want to focus on the kidney transplant just because how common it is in the PACES exam. Um, yeah, so kidney pancreas transplant. So there's a lot of I know on the chat a lot of you if you joined the WhatsApp group actually ask about where you sit the exam and stuff. Um, whether that makes any difference. And I think in general the answer is no, it doesn't because they're going to bring common patients in the majority of the time. But the only time where I think there was any utility is sort of was useful is that if you're going to sit an exam in a SPKT center, that is useful to know, for example. So, for example, any person that's sort of sitting their exam in King's, that's an SPKT center. I'm sorry, I only know the London ones. Royal Free, I think if there's an exams centers there. And that's it, because I don't think the Hammersmith do paces anymore. Um, so Um, when you get a kidney transplant, the first thing you should do is celebrate if you see this sort of J-shaped scar, and then you need to focus because everyone is going to know that that's likely going to be kidney transplant. You have to confirm your diagnosis to make sure that you can definitely feel a kidney when you palpate over the scar, and then you have to answer these sort of questions. Okay, so the first question is, okay, if that is a kidney transplant, what modes of renal replacement therapy did this patient have until they had their kidney transplant? And are they currently active? Okay, so if they have a fistula, you must work out if the fistula is active and working, and is it recently used? If they have a port, well, should be able to see that, but you may be able to see the evidence of a port or a Hickman line. And if they had peritoneal dialysis in the past, you can see some port scars on the abdomen. Okay, so you're going to think about all the methods of renal replacement therapy and whether they are currently being used. Okay, because that gives you an idea of if the transplant is working. So if they're using their dialysis fistula, that suggests that the transplant may be not working currently. And that's just your first clue that it's not working. Um, when you're looking through some peripheral signs, think about signs of immunosuppression, that should say. So, number one, do they have diabetes? Now, lots of patients with renal, so sort of transplant diabetes, will have Libras now. Okay, so you have to check the arms. So the finger prick that the textbooks all mention, you've got to move slightly away from that. That you've got to look at their arms, and so your Libra sort of usually there, and you need to have a look at that as well, just to make sure there isn't a white sort of circle. That's what a Libra would be. Dexcom looks like that, slightly differently, but it'll be a similar sort of device. Also look at the gum, obviously, and see if there's a tremor. Other things to think about if the transplant is working is to look for any signs of, say, a uremic flap, for example. That would be quite end stage, and I'm sure the patient wouldn't actually be in a PACES exam. If they're fluid overloaded, um, and we already talked about if there's other signs of other renal replacement therapy that is ongoing. Complications of renal transplant. Something that's quite often overlooked is just to have a quick look at the neck, because tertiary hyperparathyroidism is only really cured by a surgery. So you'll see a neck scar to suggest that the parathyroid gland has been taken out, or one of the glands, or one of the four glands. Um, other, I've not put all of them down because I was going to use this as an opportunity to test the crowd. Any other complications of renal transplant, you can put it in the chat. Graft failure. Yeah. Infections, malignancy. What type of malignancy? Skin, yes. So a squamous cell carcinoma. So again, that's something to whilst you're looking through and examining the patient. So in a way, what you're doing here is actually a renal transplant examination. Okay, and that's why it's so important. And I see a lot of candidates do this at the course, but you don't. You have to expose the patient at the start, and you have to work out if they've got a scar or not, because a lot of the stations depend on that. And because it changes the entire examination. Um, I'm just seeing if there's anything else. No. Fine. Now, the last question that you've got to try and answer, and that's really important, is why is this patient in renal failure in the first place? Okay. Now, I'm sure you all know, and I've all read the textbooks on what the most common causes are. Let's say they had that Libra or an insulin pump, um, or evidence of insulin. Well, you can argue that they had diabetes before, and then it was poorly controlled, and they had kidney failure because of that, and then they required a transplant. The next question would be why did they not have a simultaneous pancreatic kidney transplant? And that could just be because of location, etc. If they had a SPKT, that's simultaneous pancreatic kidney transplant, the most likely reason is that they had, horrible diabetes as well, which you will see a separate scar for. Other causes, so hypertension, well, you're going to ask for blood pressure. What other causes of renal failure could you think about whilst you examine? Good. So, um, PKD, Alports, so diabetes we've talked about. Glomerulonephritis you won't know, right? So there's nothing on examination. You're going to say it as a cause, um, but you because that's one of the most likely causes, isn't there? Um, Brilliant. So I really wanted someone to say reflex nephropathy in young people. So I think when you've got a young patient in front of you that's had a kidney transplant, you really got to ask yourself, why has this young person have it? And reflex nephropathy is that it's it's not common, but in a young person that's ended up having a renal transplant and multiple modes of renal replacement therapy, that's going to be one of them. So brilliant. Okay, just going back to that. So we talked about kidney transplant because, and again, it's because it's, I think, one of the easiest ones to sort of conceptualize. Liver transplant sort of works in the same way, the same fashion of how you would approach a kidney transplant. Um, but let's talk about organomegaly. Now, organomegaly, I think it's actually quite hard. Um, and a lot of candidates sort of ask me, how do you get better at picking up the liver or the spleen? And frustratingly, there is no better answer than you just have to feel a lot of big spleens and a lot of big livers. So this is what I actually got in my PACES exam. I got hepatosplenomegaly, um, and initially I wasn't certain about the splenomegaly, but sort of got prompted by the examiner. I've just written down a differential list below that in a sort of infection, inflammation, sort of malignancy, and infiltrative diseases at the bottom. In terms of my tips on organomegaly is yes, you've already identified that there's no scar, but when you feel and palpate the abdomen, just take a moment to just sort of step back and just see how the abdomen looks in terms of its surface. And that's probably one of the reasons why because I definitely felt the spleen, but I didn't feel the liver initially. And that's probably because the abdomen was just too full in my patient's case. But when I just took a step back and I thought actually, it, on balance, both were probably enlarged. Um, Look for other features of other systemic diseases. So is there any features of sarcoid and lupus, for example, elsewhere? So skin lesions or cutaneous lesions are your best friend, really. Um, Heart failure and portal hypertension, so fluid overload is part of your normal abdo exam. It, I think it's quite hard to pick up the other ones. So and you're probably not going to get malaria as you know, in most places in your PACES exam, um, and patients with sort of treated lymphoma might present there. But in my case, it was amyloidosis was the diagnosis. So this is more of a case of being able to pick the sign and being able to list the differentials that would make the most amount of sense. Um, yeah, so that's organomegaly. Don't know if anyone had any questions on abdo stations. No. So we're going to do neurology. Um, and I was thinking that so neurology is actually difficult in terms of suggesting what are the common neurology cases. What I would suggest is it's co the common neurology pattern of disease. So I think by and large, most neurology stations are hemiparesis, spastic paresis, and that's because there are plenty of people with stroke who are stable. Parkinson's disease, and sort of a peripheral neuropathy. And that could include a foot drop or some sort of other feature of peripheral neuropathy. What it won't be is sort of glove and stockings, sort of loss of peripheral neuropathy, because I think that that would be too basic. It would tend to be that with something else. So the most common ones are Parkinson's, a sort of hemiparesis, and I would say a sort of foot drop or an isolated nerve. Now, because I've sort of given you how I would approach stations, I think in neurology, I want someone to suggest how they would approach a Parkinson's patient and how they would score the most amount of points in a Parkinson's patient. What is involved? So don't tell me what the neuro exam is. Tell me what extra things you would do for a Parkinson's patient. If I said the stem was this patient has difficulty walking, please examine this patient neurology system, because that's what the prompt will be. You can put it in the chat. Yeah. So if you get a patient that has difficulty moving or walking, you get them to walk straight away. Okay. The first thing you do is get them to walk. Um, yeah, so I think we're all saying sort of similar things. So you get them to walk, and when you get them to walk, you'll see the reduced um arm swing, bradykinesia, and also when they turn, it'll be quite a slow turn, and maybe some instability when they turn as well. And a stooped posture. So you will see all of the signs. It'd be brilliant. So as soon as you do that, you carry on with the exam of the lower limbs because that's what you have to do in the exam. You have to complete the examination, but you add in things such as try and demonstrate, and it's much easier to demonstrate synkinesis, obviously, with the hands than it is with the feet. Writing is sort of a gold point at the end sort of thing. And the other thing is you're going to try and differentiate. So why are we differentiating? Why are we doing eye movements? What's the reason? What's the purpose of doing eye movements in Parkinson's? So, so okay, just to pick up on this point, yeah, it's Parkinson's plus syndromes, PSP. Um, you're not, so the exam does not tell you necessarily if you're asked to examine upper limb or lower limb. Okay, it's not always, this prompt is not always like that. In our courses, we will tell you to do upper limb or lower limb for the benefit, but what they usually will say is please examine this person's neurological system. The, the STEM will say this patient has difficulty walking, right? So that tells you that you should probably examine the lower limb, okay? So the point is that they will make it very clear what the symptom is or the signs are of the symptom, actually, sorry. Um, and then you then choose the appropriate neurological exam to do. The reason why that's important is because if it just said, please examine the lower limb, that means you can't actually check, you shouldn't really be checking for serine kinases, writing, and nystagmus, or all of the other bits and pieces that we've suggested. So they've kept it broad when they normally would for a Parkinson's patient to allow you to do the other bits to make sure that you've really demonstrated that you know exactly what's going on. Does that make sense? Okay. So in the PACE exam, they very rarely, for the neurostation, tell you exactly which thing to examine. Okay. And one of the thing I got in my exam was, um, ironically, it was weirdly, it was fundoscopy, but it was this patient has difficulty seeing, especially at night. Please perform a neurological exam. So, so obviously I ended up doing a cranial nerve exam of sorts, the particular focus on the eyes. You do not have to, no, you do not have to examine both. You examine, you should examine the lower limb preferentially because that's the presenter complaint. So to be absolutely clear, you examine the lower limb, okay? Because the presenter complaint was this patient has, yeah, so this patient has difficulty walking. So you do a full lower limb, and then to get the full marks or to demonstrate the full extent of your skills, really. I keep saying full marks, but you understand that the exam is not designed like that. You then look for the Parkinson specific signs. Okay. So you do the rigidity, cogwheel rigidity in the hands, the synkinesis. You can get them to write, and then you do the eye signs. Okay. And that really demonstrates to the examiner, you know exactly what you're doing, and you know exactly that this is Parkinsonism, most likely due to Parkinson's disease. Is that clear? Does that make absolute sense to everyone? Okay, so they do not tell you which system, not which system, which specific thing to examine. They will say, please perform a neurological examination or please examine this patient's neurological system. All in 5 minutes. Yeah, yeah. Um, if you do not manage to get them to write, you're not going to fail the station, to be clear. Okay. If you want to do one of those things, you will not fail the station. It's about the way you do the exam, if it's slick and if it's consistent in your presentation and the questions that you answer. Okay. But it is time pressured. The neurology station is hard for that reason. Any sort of other questions on common cases in neurology or I hope no one's feeling daunted about doing a full Parkinson's exam, but the expectation is that you try and do as much of it as possible in the sort of 5 to 6 minutes. So, I got Guillain-Barré syndrome. Yeah, so that's sort of a peripheral neuropathy, isn't it? Um, and what's more likely, well, is sort of CIDP, so sort of chronic inflammatory demyelinating polyneuropathy, so chronic GBS in a way. Dizziness in walking and vision, cranial nerve exam. Um, sorry, I'm not entirely sure what the question is. Dizziness in walking and vision. I mean, oh, are you asking what the differentials could be? Fine. Um, well, MS could potentially be one, but I think it's difficult without knowing entirely what the station is. I think the problem with this question is we need to know whether it's an upper motor neuron signs father. So I'm not entirely sure, but if you message me, probably I can post my answer on the group as it were. But any other questions on sort of what else sort of expect? Um, what I will say is be very clear on the difference between upper motor neuron lesions and lower motor neuron lesions. Okay, so MS, for example, has to be by definition upper motor neuron problem. So it must have upper motor neuron signs, and then your other differentials must also be upper motor neuron. If you do a situation where you say, oh, this could be a let me give you an example. If you said MS and Guillain-Barré syndrome, you're you're going to lose marks, or not score in the satisfactory column, as it were, in the differential diagnosis bit, because you've offered two differential diagnoses that are fundamentally different in where they act. Okay, so neurology is about where the lesion, um, and what is the lesion. I'm going to move on. Um, so I thought about other cases that are common. Um, and the reason why I've thought of these cases is because if you think about, again, it comes down to what you're going to get in terms of stable patients to be able to turn up to the exam. So acromegaly are patients, even if you cure the disease, they will have signs. The prognathism does not go away, the frontal bossing does not go away, and the interdental spacing doesn't necessarily go away unless they've had some treatment. So even treated acromegaly will have the signs of acromegaly, all right? Neurofibromatosis is, there's loads of questions that can be asked about that, and they've got plenty of signs, neurofibromas. Um, they tend not to ask for you to examine the eye, but there's lesion nodules. There's so much that can be examined. Obviously, skin lesions, psoriasis, and eczema are quite easy to find patients that have bad or good clinical signs, as it were, for the exam. Sarcoidosis, Marfan syndrome, because you can use it in two different stations. So these are sort of other cases I think that do turn up, and this is some of these stations are more outpatient settings, aren't they? Because how many people see acromegaly? Acromegaly is not that common unless you work as an endocrinologist. Um, I put down Cushing syndrome, and I've um, been thinking of that actually, um, because it's relatively far more common as an endocrine condition than acromegaly, part because the most common cause of Cushing syndrome is iatrogenic steroids. Um, it as a station could appear. Okay, so not necessarily Cushing's disease, or not necessarily adrenal Cushing's, but Cushing syndrome just because of excess steroids of whatever cause could appear as a station. But acromegaly and Cushing's will obviously be station five stations, or sorry, consultation stations. Um, so all of these cases um, will probably present themselves, I think, in the clinical consultation stations. Marfan's could obviously be in the cardiology station, and sarcoid we talked about could be in other stations. And as a clinical consultation, that's a very different approach, which is why I'll sort of refer you to sort of the clinical consultation sort of webinars on how to approach patients with this. But again, it's as what you do on a daily basis, just take a full history and examine for both the signs of the condition that you think they have and also the complications. And that's really important. Always, um, always examine for the complications of either the condition they have or the treatment they would have had. Okay, so psoriasis, for example, steroid creams, um, and rheumatoid arthritis, they may have some methotrexate, so you can examine for complications or ask for complications of that. Um, that's the course again at the end. And I wanted to just give sort of plenty of time to ask for any questions on common cases, questions about PACEs in general, um, and anything else that you want to ask essentially. Thank you so much for listening. I've just seen, sorry, I think I misunderstood your question completely, and I'm so sorry, Father. You're asking, oh, sorry, yes, I agree. So you're asking what's examination, and that would be an examination of the head and neck, so cranial nerve exam. Um, quick question. If I do part two written in October, do you think I can sign up for, or is that too much stress? I I think they are very different exams. So I think um I would probably leave a gap if I were you, but if you had to do it, it's not impossible. Part two, the basic exam builds on part two knowledge, doesn't it? So, um, it is possible, but you may want to have a break because paces revision needs to be quite intense. So it has to be um, you would have to sort of commit yourself to going on the wards, seeing patients on the take or whatever in your local hospital. Can you I can you bring up common cardio stations? Yeah, can do. So yeah, so Joanna, I would probably spend a bit more time if there was no rush, but you certainly can do it. It's just that you just have to be wary of as soon as January hits you'll have to hit the wards and hunt for patients. Um, if you must say hepatomegaly, it is no, there's no such thing as an automatic fail. You will get borderlined if you miss an important sign as the truth. Okay. Of in terms of identifying signs. So what I suggest is that so the mark scheme is that you have all of so it's like a driving test. You have all of these sort of domains of the PACES exam. So people fail. People do not fail outright usually. People fail in a section. Okay, so they have too many minor faults in a section, and the sections that people fail in PACES because of that is too many minor faults, as it were, in identifying physical signs, differential diagnosis. So those are the two. Clinical judgment, maybe, but it's the two. These are the two. So you're not going to fail paces because you miss one sign. Okay, and that's really important because if you miss a sign, just remember that you have all the other stations. So it's a global assessment. Yeah. You don't fail paces because you fail one station. You don't fail paces because you fail you fail to, pick up one sign. That's not how it works. You just have to remember that you're probably, you've just got to forget about it on the day. And whilst you're waiting for your results, you've got to remember that even if you miss an important sign, you may just get a borderline, you know, because hepatomegaly and splenomegaly are, I would suggest are harder signs. And if it's hard for you, then other candidates would have found it hard. And potentially the examiners may have found it hard, so they may not have necessarily recognized it. My patient in the cardio station was not okay with carotid palpation. Should no. So you can always ask patients, and I've said this on the course for people who have attended. You can always palpate the subclavian pulse. Okay, so that's just above the clavicle. So just if you feel for your own pulse just above your clavicle, and it's sort of in the supraclavicular fossa, you can feel your own pulse, and then I think it's actually far better than a carotid pulse. Radial's peripheral, so it's too far to time the pulsations. Andrew, so do you have any tips for consultation stations? Is it worth doing a very wide history as not to miss things? So, because it's you've got time to do that, the answer is yes. However, if if the so if it's heart failure, for example, um, I would try and focus on a cardio systems review. Okay, so try and just remember it is a focus exam, and you you do want to spend time really nailing down the cardio questions, for example. So not at the expense of missing things. So I wouldn't suggest. I think just I know you probably don't mean this, but I wouldn't just ask lots and lots of questions because that can confuse you. Right. In terms of repeat regarding palpated pulse, so the radial pulse is not. It's usually examiners do not accept as being a central pulse. So if you're timing the radial pulse with your heart sounds, it's not as accurate as doing it for the central pulse. And the central pulses are the carotid pulse, which is what most people would want to do, or the subclavian pulse. Okay. So I would suggest that you stick with I would personally do the subclavian, sort of just above in the supraclavicular fossa, but if you're comfortable doing the carotid, do the carotid. Definitely do not do the radial, okay? The radial pulse is not accepted. Because you won't be timing it correctly. It won't give you the na same volume, nature. You've palpated the radial pulse on the way up. Okay, it's not a useful pulse later on. The radio pulse is only used for one thing, and that's for diagnosing AF, or at least suggesting an irregular rhythm. Any other questions at all? I hope I answered your question, Andrew. So I wouldn't necessarily do a wide um sort of systems review just because of the nature of it being a focus thing. Definitely you can put it with the subclavian, that's a central pulse. Yeah. I think it's far more comfortable for the patient actually because you just put your hands there. Yeah. Okay, any other questions at all? If there are any questions, did you say synkinesia in your exam? If so, how do you measure it and what does it show? Synkinesia is a clinical sign of Parkinson's in particular. Um, so synkinesis, even it's so what you can do is you check for cogwheel rigidity and you ask the patient to tap on their thigh and it eases the rigidity as it were. I don't know if you've basically the best way to explain this is for you to go come and examine. Oh yeah, brilliant. I think you've understood it. But yeah, just next time you see a Parkinson's patient, um just 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 reinforce it. I know relying on because I got my ears adapted. So yeah. So I'm sure we can all pick up murmurs and we can time them, but I'm telling you, you must feel for a pulse. Okay. And if your patient does not want you to do carotid, allow the carotid pulse, just see if they are happy for to feel the pulse. And if they're not happy, well, you've asked them and you can move on and you know, you can feel the radial pulse as a compromise. Okay. Even though we know that is not as accurate as feeling a central pulse. Should we do? No, I do not think you should do a maneuver like that, partly because it could go wrong. Only offer, agreed. Definitely do not do that. Um, just because of time. Any other questions? I'm quite interested that there's so many patients that are refusing for carotid palpation. Um, but I guess that's probably one of the reasons why I do subclavian as well, because it just gets you into awkward positions. Yeah. I mean, one tip, by the way, for carotid pulse palpation is that Andrew makes a good point. When you do the cardio exam, the gold standard is actually to listen to breathe on the way down. So when you sort of go from the head and neck and you just listen to breathe to make sure that they don't have stenosis, because I'm sure you know the reason why is the theoretical risk of dislodging a clot and causing stroke. But so you can listen for breathe down there. But you know, yeah, I've not come across many patients that have refused sort of carotid pulse sort of examination or palpation even. And like I said, you've got the subclavian in the back pocket. Any other questions about any other stations? I'm gonna go back to the other cases bit at the end. Wow. If there aren't any questions, I'll just keep the slide at the back. So there are, like I said, um, PACES courses are sort of important because the bits that you don't see in hospital, which are the stable patients with the Eisenmengers and the niche stuff that do turn up, once in a while, they're there, but actually you get to focus really hard on the COPDs as well, with the good clinical signs that they always have good clinical signs because they're going to try and bring patients that have reliable signs to the exam, and sort of expert patients, as it were, in inverted commas. Um, and it's nice to just make sure and consolidate that in a way. Um, and things like acromegaly, for example, it's not something that you're going to see um, in um, in the awards, most likely, right? Or if you so there's chances for things like that on courses. What was your neuro opt-out case in the end? Oh, sorry, I didn't actually mention it. I think I may have mentioned it in a different webinar. But it was retinitis pigmentosa. Um, I, I think it's quite uncommon to get retinitis pigmentosa as a neurostation. Partly because I finished the station quite quickly. Um, and I think that retinitis pigmentosa in the old exam would have been a sort of station five situation. But in the new sort of setup of PACES, I'm not sure retinitis pigmentosa really has a place. Partly because I think in a neuro station you probably want a bit more of a thorough exam. But yes, so retinitis pigmentosa was my neuro station, but it was actually essentially an opt-out case. All right. Well, I'm on the group if there's any other questions, so you can message me. I hope I did answer all the questions as we went across. And yeah, looking forward to meeting you all on the course. And also just if you've got any questions, please don't hesitate to ask. Thank you so much for your time.